Welcome back to my channel, Pattern of Good Works. My name is Donna, and today we will be in chapter number 7. The book is called The Specialty Practice of Rehabilitation Nursing, a Core Curriculum, the 8th edition. We will be on page number 110. And what we'll be looking at today is reimbursement. You'll see the header says, Reimbursement for Healthcare Services. And Merriam-Webster says that reimburse is to pay back. So let's take a look at how any organization will receive payment back. So for reimbursement for healthcare services, there are two types or two classifications. There are broad groups. One is fee for service and one is capitation. They are vastly different. So fee for service is typically under fee for service, there's reimbursement payments are provided for each defined unit of service, and a greater number of service units results in an overall higher payment. So this could be someone goes to the doctor and has a visit, someone has a blood test, someone has a procedure. The more of these instances or episodes, there's going to be a higher payment for fee for service, which is definitely the inverse of capitation. So capitation now is a fixed payment to providers based on each covered life or enrollee, and the payment is independent on the amount of services provided. So you can be, or the individual can have 20 episodes, 20 blood tests, 20 times they see the physician or nurse practitioner, or 20 different procedures. They're still going to only get that fixed payment for this episode. Nextly, we'll talk about cost-based reimbursement. Cost-based reimbursement, you'll see that there is a provider again and a payer. The payer agrees to reimburse the provider for allowable costs incurred. Allowable costs incurred. And when it provides services to the insured population. So the cost-based reimbursement almost ensures that the provider will be reimbursed. The provider is going to be covered by the payment from the payer. So still under the header of fee for service, there's something called charge-based reimbursements. And these are typically negotiated rates that are discounted facility-specific charges. The payer and the organization have set a specific amount or have a specific list of charges that the payer will pay out at a specific time. Another term under fee for service is prospective payment systems, PPS. And payment rates to the provider are predetermined based on the client's medical diagnosis and other clinical information. The predetermined payment rates are designed to cover costs and intended to drive efficient care. So what does that mean? What PPS really does is, for example, if the person has a medical diagnosis, say a right MCA stroke, they are given that right MCA stroke, depending on other client conditions, $5,000. Or if a patient has, for example, a TBI, they are classified as a TBI, they will get $10,000. A trach vented patient, for example, would get maybe $15,000. This is it. Now, a couple of weeks ago, we talked about negative patient outcomes. This same vented patient, this same patient with the MCA stroke, this patient who has the TBI now has a fall with injury. Now that fall with injury, they have to have an acute care transfer to an acute care hospital. They're going to share. They're not going to get all of that money that they would have had the patient not had a negative patient outcome. So it behooves us to keep our patients safe, to prevent a negative outcome, so that they will have, because the negative outcome pretty much is going to impact that payment that organization would have had. I also want to mention at this point, there are men and women who are also called PPS coordinators who will be able to ensure accurate billing. They will also work with compliance to maximize the Medicare and Medicaid reimbursement for a uh, earth. So, if in my last example of the patient who had the fall with injury at a freestanding hospital, if there was a pressure injury, maybe the patient's skin was intact when the patient was admitted, and then on discharge, someone captures that there was a stage 3 pressure injury, it's usually the PPS coordinators that will go to the electronic health record along with the wound care nurse to really look and see whether or not this was some sort of true occurrence, or was this, someone clicked some erroneous button and this is really not really a true pressure injury. So the PPS coordinators work very hard at freestanding hospitals and also at acute care hospitals to make sure that the electronic health record is in compliance so that we can maximize the payment and we won't get, for a lack of a better word, a ding and lose money or lose funding from the payers. Although the book doesn't talk about value-based purchasing, this is a great place to talk about it. So value-based purchasing is a concept that those people purchasing healthcare services should hold providers accountable for quality of care as well as costs. So they want to contain the costs, and they also want to ensure that hospitals are providing patients with quality care. And hospitals also should ensure that the nursing staff are providing not only quality service, but also ensuring safety of the patient. So they want to decrease mortality and complication, healthcare associated infections, increase efficiency and cost reduction. Lastly, I want to talk a little bit about the 60% rule. So on page 110, it says inpatient rehabilitation facilities, which include freestanding rehab hospitals and distinct rehab units within general acute care hospitals. So an acute care hospital could have 28 beds, or it could be a freestanding hospital where they're not connected to an ED. They just have only rehab services. These locations where they are giving or providing intensive rehabilitation services, it could be physical, occupational, speech therapy at a hospital level care to clients after major illness, injury, or surgical care. So inpatient rehabilitation facilities, IRFs, clients must be able to tolerate and benefit from 15 hours of therapy weekly. The 60% rule is a criterion used to define IRFs. It requires that 60% of patients admitted to an IRF have one of 13 qualifying medical conditions. And here are the conditions. It could be a stroke, spinal cord injury, congenital deformity, amputation, major multiple trauma, hip fracture, brain injury, neurological disorders, multiple sclerosis, Parkinson's disease, burns, 3 arthritis conditions for which aggressive and sustained outpatient, both knees or both hips, when body mass index is 50 or higher, or the age is 85 years or older. The IRF standardized item set is the Inpatient Rehabilitation Facility Patient Assessment Instrument, better known as the IRF-PI, which includes a demographic, diagnostic, and functional status data. Data are collected on admission and discharge, and admission data are used to categorize each client into payment groups. So it's so imperative that that tool is completed correctly. And it says Medicare implemented a per discharge IRF PPS in 2002 for Medicare fee-for-service clients. And the PPS payments are expected to cover all operating and capital costs, which certain high cost ancillary services paid separately. The classification system for the IRF PPS is a case mix group based on a primary diagnosis, the functional status data, and age reported on the IRF PI. So all of this is taken into account when specifically for payment services. So it's important that as we gather data, as we do our assessment, that we do it accurately for admission as well as for discharge. This week in review, we talked about reimbursement, and we learned that reimbursement means to pay back. We talked about fee for service, capitation. We looked also at the 60% rule, or the criterion for the 60% rule for IRFs. We also talked about value-based purchasing, and we talked about tools. Although way back when we used FIM, now we use the GG codes, we still have to continue to ensure that on admission and discharge, we're capturing our patient accurately and completely to ensure that we get the required payment. I want to thank you all for coming along on this journey. Continue to like, comment, and subscribe. We hope to see you next week. Be well. Bye-bye.